Assalamu alaikum and good morning everyone. My name is Salman Bafageeh. I'm currently at my second year of residency program of cardiac surgery from Saudi Arabia. I would like to thank the Gulf Committee and my mentor, Dr. Uthman for giving me the privilege to present our work, 5 years experience of robotic assisted hybrid coronary revascularization. I do not have any financial disclosure. So this is a brief timeline showing the history of CABG in the last 7 decades. We have witnessed different periods and different phases which allowed us to understand the value of CABG in serving patients with coronary artery disease. The most important trends in the last recent years focused in 2 directions. The first one is to promote more arterial revascularization, and the second direction is to decrease the burden of surgeries through a minimal invasive approach. Currently, we have different approaches to address minimal invasive coronary surgeries, from a mini thoracotomy mid-cap to a more advanced T-cap. So with the introduction of robotic technology, now we have several advantages. We have a better quality of life, quicker recovery, low hospital stay and ICU stay, clean surgeries, better precision, hence, and better view. So hybrid coronary revascularization, it's simply LIMA to LAD and PCI to other territories. The first HCR was made at 1996, and 3 years back we have published our early experience of robotic assisted HCR. So we have examined 261 patients from July 2018 to July 2023 who underwent robotic assisted HCR at King Faisal Specialist Hospital and Research Center, Jeddah. We carefully selected our candidates. These are the inclusion and exclusion criteria. So this is a brief algorithm showing all comers who are going through the process. We divided our patients into acute coronary syndrome and stable coronary artery disease. Patients with acute coronary syndrome, culprit lesions were treated first, while patients with stable coronary artery disease, the cases all were discussed in heart team meeting. Cardiac CT and PFT were done prior to surgeries, and all patients were having a complete revascularization and LIMA check. So this is a typical case of robotic mid-cap. The first thing, we insert 3 trocars through the 2nd, 5th, and 7th intercostal space. Then the robot is docked, and the robotic arms is inserted through the trocars, and the surgeon is controlling the surgery through a console. This is brief clips showing the LIMA harvest by the robotic technique. So small branches were controlled through cautery, and large branches was controlled by a clip, as seen in the video. So after we harvest all the LIMA, we clip it, divide it, and retrieve it for later mini thoracotomy. So this is a 5 centimeter left anterior mini thoracotomy. LIMA is retrieved. Then we insert a Nuvo stabilizers for the anastomosis in an off-pump fashion with small scars and a LIMA check. So these are our baseline characteristics. We included 261 patients, 86% were male. So PCI to RCA was made to 66 patients, PCI to left circ was made to 55 patients, and PCI to both were made to 140 patients. Our average operation time was 164 minutes. 6.8% of the patients needed blood transfusion. 1 patient converted to sternotomy due to hemodynamic instability, and the average hospital stay was 6 days, and average ICU stay was 1 day. 4 patients needed re-exploration for bleeding. 2 patients had complication of hemothorax, and 7.6% of the patients had a post-op AFib. So 5 years follow-up, our mean follow-up was 3.4 years. All patients were yearly clinically follow-up. 96% were free from angina. So 10 patients were admitted for acute coronary syndrome. Coronary angio were made, and there was a patent lima to LAD. PCI to RCA was made in 7 patients, and to the diag in 3 patients. So our 5-year survival rate was 99.6%. We didn't recorded any cardiac death or stroke. So in conclusion, the establishment of robotic HCR program is feasible with great potential. Robotic HCR merges the long-term benefit of lima to LAD grafting and less invasiveness revascularization strategy with PCI to other territories. This was my talk, and thank you.